What I'll be talking about is the glenoid bone issues, a little bit about Latarjet, but concentrating not on the technique, but on the biomechanics of bone loss and what's been out there as far as Bristol versus Latarjet. Disclosures. Humeral bone defects was first brought to our attention by Steve Burkhardt and Joe DeBeers, showing that in the athletes, particularly rugby players, there can be almost a 90% recurrence rate with bone loss. And we've learned that doing a well-done arthroscopic repair still will not work if there's significant bone loss. The question that immediately brings up is how much bone loss and how do you record this? Julie Bishop and the Moon Group looked in cadavers where they created up to 40% bone loss and looked at the different modalities. In essence, the 3D CT was the best as far as kappa values, followed by 3D CT, MRI, and then X-rays really weren't all that helpful. However, in Europe, the Brigano view in a study has been shown to be valid and reliable for bone loss assessment. So once you see it on 3D CT, how big of a glenoid defect is critical, and when will a soft tissue repair not be effective? We looked at this a few years ago in our laboratory, and essentially in a cadaver model looked at the Bankart lesion, created a glenoid defect, repaired the Bankart, and also did Latarjet bone grafting. And it was interesting as we created the defect, once we got past 4 millimeters, there was significant instability. After we did a repair, we restored stability, except if you got over 6 millimeters, and certainly 8 millimeters. Putting a bone block in restored stability significantly in that procedure. So in essence, we felt that 6 millimeters defect was a critical size, and that's about 25%. Other authors have also shown roughly that 20 to 25% range is a critical defect where you need to consider doing something more than just a well-done arthroscopic repair. The Latarjet procedure obviously is one that's been out there the longest. But again, you can see in this patient of mine, you can see on the x-rays there's a hint of bone loss. I think if you look at x-rays a lot, you can probably see on the right side there's a loss of the sclerosis you normally see. But when you look at the 3D CT, it's quite obvious that there's about 30, perhaps 40% bone loss in this patient. And he responded very well to a Latarjet procedure that extended the glenoid arc of the joint in addition to the sling effect. We do know that the procedure has had very long-term follow-up in Europe and some excellent reports, and Dr. Walsh will be talking more about this. But I started thinking, and Gilles and I had a conversation several years ago on what are the true biomechanics? Why does this technique work? And that led to a collaboration in our laboratory here looking at the technique of the bony effect, ligament, and muscular effects of the procedure. We tested this in end range and mid-range in a cadaver model with different tension in the conjoint tendon. And you can see when you do the Latarjet procedure, you restore stability with the different tensions. It was interesting, once you remove the conjoint tendon, there is a loss of about 80%. So this demonstrates the very importance of the sling effect of the procedure. Interesting, removing the Ca ligament, repaired to the capsule, didn't really add all that much, only about 20%. This is end range of motion. At mid-range of motion, we saw, again, the benefit of the bone block Latarjet procedure. But if you take down the strap muscle, the conjoint tendon, you lose about 70% of the sling effect. And we found that the coracoacromial ligament didn't add anything at this. So when I do this procedure now, I don't worry too much about suturing the Ca ligament to the capsule, particularly since it doesn't affect the mid-range. So we can see, again, looking at end range and mid-range, a significant effect that the sling does apply. So it's important not just to look at this as a bone block procedure. It's extending the glenoid arc. It's not acting as a block. Where to place it, it doesn't seem to matter a whole lot whether it's done classically or on its side. I think George did a study also looking at that, and it really didn't show both techniques seem to work. Now, distal tibial allograft has been advocated by the group at Rush, and they've got excellent results using fresh tibial allograft. However, it's unclear how allografts heal overall compared to the autograft of the coracoid. Move this wrong. And then we can see also that the dynamic sling effect actually was also looked at by George's group also, and showing again the importance of the sling effect preventing dislocation. At special surgery, Josh Steins and others also showed the importance of the conjoined tendon to resist anterior translation in this procedure. But the question does come up: is the bone block itself necessary? Which is an interesting concept. This was a study looking at 8 cadaver shoulders and compared the intact to a 20% bone loss, similar to the procedures that we had done in the laboratory. It was interesting that both the classic Bristow and using just the soft tissue transfer of the conjoined tendon were both effective in restoring stability. And they felt that this study showed the importance of the sling effect, but then doubted whether we actually needed necessarily to add a bone block in all these procedures. This was a new look at whether the bone block itself was necessary. Looking at Bristow versus lateral J, these are 2 different procedures. They've been often lumped together as the same. And Dr. Athwal looked at this with his group in Canada, showing that the Bristow actually restored stiffness to the intact state in only 4 out of 12 shoulders in their cadaver model. Yet all were stable after the lateral J, and felt that the lateral J confers superior stabilization, at least in the cadaver model, compared to the Bristow type procedure, which is, of course, based on a single screw and about a centimeter or so of the distal coracoid. We do have to remember that there are short-term potential complications of the lateral J. This is a study from Boston looking at patients, all of whom had prior surgery at 6-month follow-up, and the complication rate approached 25%. And infection and nerve injury. In my own practice, I've had one lateral J procedure that was infected, and I had one patient that had a suprascapular nerve issue that resolved at about 2 to 3 months, and I think we're all concerned about neurologic injury. In this country, in North America at least, most of these procedures are done for revision type situations, and that's where we, of course, worry more about nerve injuries. But in the primary setting, which is more the European experience, the complication rate actually has not been as high as I think the North American perception of the complication. So in summary, I would say that the glenoid defects that are greater than 6 millimeters require more than a soft tissue repair. The sling effect, I think our study and multiple studies now show a significant advantage of that in the lateral J procedure, and that the lateral J is not without potential complications. It does alter the shoulder anatomy, and we should also consider potentially doing open instability repairs. Thank you very much.